Fixed doses are usually right. Therapeutic window might be tight. Suboptimal or supranormal level variation might occur. So the drug monitoring help and right dose.
Why we need to monitor the drug levels of antibiotics? Let's hear it once again from the legend himself, Dr. Atul Patel, sir.
So good morning once again. I'm here to speak on therapeutic drug monitoring for antimicrobials, especially the antibiotics. Now question arises like all the pharma company when they are doing a research on any new molecules, like they have done optimal studies in phase 1, phase 2, like phase 2 is a dose ranging study, and they have find out and they have derived a dose, optimal dose for the treatment of so and so infection, then why we should perform therapeutic drug monitoring? So this is a question. The reason here is that like when we talk about the ICU admitted patients, there is a significant difference in the drug metabolisms, and this difference in the metabolism occurs because of the systemic inflammation. This systemic inflammation increases the activity of CYP3A4 system. So this enzyme is responsible for the metabolism or the handling of more than 60% of the drugs. And because of the inflammation, the activity goes up, so it will metabolize very efficiently of any molecules. I'm sorry, inflammation reduces the activity of CYP4, so the efficiency of metabolisms of this drug goes down by significant. And that leads to the overexpression or the increased exposure of these drugs. So the metabolism is affected by the severe systemic inflammation. The another important issues in the ICU admitted patients is the organ dysfunctions. So invariably, these patients have either renal or the liver compromisation or the liver insult because of the critical illness. And this leads to the over or the under exposure of several drugs, because these are the two very important organs which metabolize, which handles most of the drugs. There will be a change in the volume of distribution that we are going to study in next slides. And several patients, they are also receiving the renal replacement therapy, which definitely affects the drug metabolisms. So what are the important parameters, pharmacokinetics and the pharmacodynamics parameters, which changes the antimicrobials in critically ill patients? The most important would be there will be altered volume of distribution, and this is very commonly seen. The reason is because of the severe systemic inflammation, there will be a leaky capillaries, and this leads to the increase in the interstitial fluid with the diffusion of the drug or the entry of drug into the interstitium. And that's how the effective circulating concentration will go down because of the leaky capillaries. The IV fluid loading is a very important principles of handling critically ill patient who has come to with the ICU with a septic shock. So this fluid loading will also leads to the dilution and leads to the underexposure of the drug. We know that the serum albumin is a very important acute phase reactant, meaning that like with ongoing inflammation, there will be rapid reductions in the serum albumin level. And we know that most of the drugs which are protein bound or the albumin bound, the level gets distorted. And that's the reason that we need to check for the drug level in this group of the patients. And the patient with overweight, like obesity. Apart from this change in the volume of distributions, the another important thing that you may see in the critically ill patients would be the altered clearance. The augmented renal clearance is not uncommon in the patient who is admitted to the ICU with sepsis. And because of this augmented renal clearance, there will be a suboptimal exposure, or the drug level will achieve the suboptimum plasma concentrations, and that leads to the treatment failure. The renal replacement therapy that your patient is receiving, especially the CRRT, these patients are also having the augmented renal clearance, and the drug metabolism is definitely affected. So these are the very important PKPD issues in ICU admitted patients. Now coming to the next questions, which drug that I'm going to monitor in my critically ill patients? So obviously, why the drug monitoring is required? The infection-related mortality in ICU patient is very high. The reason is that there is a high burden of the infections in ICU patients. We all know about it. There will be a rising antimicrobial resistance. So yesterday also, like, we were talking about RRR. So resistance is very rampant in ICU admitted patients. And the suboptimal drug exposure is very common in ICU admitted patients as compared to the patients admitted into the general wards. And reason we have already discussed. So optimizing the ICU admitted patients antimicrobial therapy with the help of therapeutic drug monitoring improves the outcome. It also reduces the toxicities associated with the antimicrobial therapy and also helps in antimicrobial stewardship program by reducing the chances of emergence of drug resistance. So coming to the very important question, which drug requires the therapeutic drug monitoring? The two class of the drugs, they definitely requires the TDM. One is the aminoglycosides and the second one is glycopeptides. Most commonly used glycopeptides would be vancomycin and the teicoplanin. And TDM is also recommended only in specific situations. So not for all the patients, for linezolid, beta-lactam antibiotics, colistin, fluoroquinolones, and daptomycins. So these are the very commonly used antimicrobial where we are going to use therapeutic drug monitoring. Now, what are the rationale why the aminoglycosides and the vancomycin requires therapeutic drug monitoring? The rationale is very simple because both this class of the drug, they have narrow therapeutic window. So if your drug exposure increases, both these group of the drug will end up into the toxicities, either nephrotoxicity or the ototoxicity. And if your exposure is less, then you will lose the therapeutic efficacy of these drugs. So there will be a very narrow therapeutic index for aminoglycosides as well as for the vancomycin. And that's the reason that we have to monitor this therapy very closely by monitoring the drug level. For linezolid and beta-lactam, the purpose of going for a therapeutic drug monitoring is to optimize the exposure, right? This is very important because if we know that like linezolid is associated with significant toxicities, and if you are using a beta-lactam and you are not achieving the adequate level, then you are losing the efficacy of this beta-lactam. So you invariably end up with either toxicity when the exposure increases or you are losing the efficacy. For colistin, daptomycin, fluoroquinolones, and tetracycline, like when patient is having a special situation like renal replacement therapy, where you do not know the renal clearance, and there is a daily changing in the renal clearance, because if you look at an examples of patient who is on intermittent maintenance dialysis or intermittent hemodialysis, the patient's renal clearance on the day of dialysis is much higher as compared to patients when the patient is on off dialysis, right? So this is how like the drug levels changes in ICU patients. Now, another important things, because many a times like we know like we have to perform a therapeutic drug monitoring for these medicines, but we do not know when to time. So timing is very important to understand like when we should sample a blood to check for the therapeutic drug monitoring. And this, the timing is always agent specific, and this depends on the half-life of the patients and when the drug is achieving a steady state level. So generally we look for the two levels, that is one is the peak level. Generally for most of the drugs, except for the aminoglycoside, for most of the drugs, the peak level is studied 2 hours after the infusions, and we also check for the trough level, right? So just before the next dose, we again draw blood to check for the trough level. For patient who has a severe critical illness and patient is having unstable renal the component, we generally go for a frequent and the early therapeutic drug monitoring. So to understand what is a steady state level, I think this is a very important concept that we need to understand. For most of the antibiotics, the steady state level is achieved after 3 to 5 half-life of the antibiotics that we are using. So what is steady state level? Let me take you to the slides. Yeah. So once you start administering antimicrobial agents, like you will notice a significant fluctuation in the levels, at peak levels as well as the trough level. And after a few days, the persons will achieve a steady state level, which is probably within the range of therapeutic the success, right? So the time taken by the medicines after administration, like it could be a few hours to several days before it achieves a steady state levels. So this is a time where you should go for, if you are aiming a peak level, you should sample a patients after 4 days, if this is for that antimicrobials. So, but for most of the antibiotics, it takes 3 to 5 half-lives to achieve steady state level. The aminoglycoside generally achieves steady state level after 3 to 4 dosage of the administrations in a patient who has normal renal functions. So you can sample the patient's blood at 24 to 48 hours after initiation of your aminoglycoside therapy. The glycopeptides, they generally achieve steady state level after administration of 4 to 5 doses. So for vancomycin, generally I collect a sample after 3 days of administration. For linezolid, steady state level is reached little earlier because it is having an excellent pharmacokinetics parameter, and so you can check for the linezolid level 2 to 3 dosage. For beta-lactam antibiotics, steady state is generally achieved very early, within 24 to 48 hours, and for those patients who are receiving continuous infusions of beta-lactam antibiotic, you can collect blood sample at any time, so there is no need to wait for achieving a steady state level. So coming to the aminoglycoside, so what we do, like after initiation of aminoglycoside infusion, after completions of 30 minutes infusion, so that is total 1 hour, right? The infusion lasts for the 30 minutes, and once the infusion is completed after 30 minutes, we collect a peak level. So after 1 hour of starting infusion, we collect a peak level for aminoglycosides. The second sample, like after 8 to 10 hours, if we are also aiming for a trough level, and if you are using a multi-dosage, then you can also collect a sample just before the second dose. And for vancomycin, like previously, we used to take only trough levels, and trough level between 15 to 20 was used as a success for therapy. But nowadays, the concept has changed. So current consensus is used to have AUC guided monitoring of vancomycin. So this is little complex things where we are going to take a peak level as well as the trough level for monitoring the vancomycin therapy, and having a 2 readings, that is peak level and the trough level. The complex software utilized by the pharmacologist or the infectious disease pharmacologist, and they calculate the AUC. So AUC of more than 400 is considered as a success of therapy, but still, like trough level is collected just before the 4th dose. So let us, and coming to the beta-lactam, so we told that, I mean, for intermittent dosing, we generally collect the trough levels for this, all the beta-lactams, including the meropenem, and like for patients who are on the continuous infusions or the prolonged infusions, you can also collect the trough levels between the mid dosage of infusions. Now coming to the real clinical applications of monitoring antibiotics in day-to-day clinical practice. So this was a young female who has a dengue fever, and she has received infusion at home. She was a gynecology resident, and she came to the hospital with high-grade fever, dry cough for 2 days, and left-sided pleuritic chest pain, and she was breathless for 1 day. And she received a diagnosis of dengue fever, and she took treatment at home with IV fluids. So when she came, like on examination, she had a significant thrombophlebitis. Here you can see that. Toxic look, conjunctival congestion, skin erythema all over the limbs, abdomen, significant thrombophlebitis, high temperature, tachycardia, tachypnea, and the blood pressure was normal. This was her X-ray chest, raised CRP, platelets were started recovering, and mild transaminitis. But the important thing is that she has received empiric antibiotics, ceftriaxone and vancomycin, looking at the thrombophlebitis and the respiratory symptoms, suspecting the septic pulmonary thromboembolisms, and also applied mupirocin cream over the thrombophlebitis, and patient was shifted to the ICU because of the progressive hypoxia. So in this patient, like you can see that there are multiple peripheral opacities, right? So looks like septic thrombophlebitis plus areas of consolidations and the pleural effusions. And the blood culture grows MRSA after 33 hours of incubations. So the C has probably the thrombophlebitis into the periphery, which has leads to the septic pulmonary thromboembolism, and that was a cause for her clinical worsening. And look at the drug susceptibility, vancomycin MIC was 1. So here thing is that like the patient's source was forearm, because in MRSA we always look for the source, try to identify and control the source for the management of this patient. And there was no pus collection, so there was no point in draining the things. Vancomycin was also favorable, and vancomycin was already started on the day of admission, and there was a daily fever spike of 102. But when we check for the vancomycin trough level, it was 11.3 microgram per ml. So obviously this is MRSA bloodstream infection with septic pulmonary thromboembolism, and the vancomycin exposure was suboptimal. So how do we increase the vancomycin? So when we are using vancomycin in a loading dose of 25 milligram per kg state, followed by 15 milligram per kg 12 hourly, when you have a suboptimal exposure, you increases the vancomycin by 250 milligram with every TDM checkpoint. So if still if you are not achieving, you can further increase by 250 milligram. So vancomycin dose was increased from 1 gram to 1250 milligram 12 hourly, and the repeat trough level was achieved into the therapeutic range, that was more than 15. So target of 15 to 20 milligram is taken as a surrogate markers for AUC MIC of 400. So remember that current guidelines or the current recommendation is that you have to use vancomycin AUC for the management of your patients, and probably if you are achieving 15 to 20, then you are well when the vancomycin MIC is less than 1. So for vancomycin therapy, you need two important things. One is therapeutic drug monitoring, and second is your organisms and the MIC. So if my vancomycin MIC is, say for example, 1 rather than the 1, if it is 2, then probably I am not going to use vancomycin to treat with these levels, right? So you need two things, MIC as well as things. And the blood cultures repeated after 72 hours became sterile. So the meta-analysis says that when you use the vancomycin TDM guided, there is significant associated with the clinical efficacy. You can see that almost all the clinical trials except one, they are showing the success when you are using vancomycin as a TDM guided therapy. And when you are using TDM, the chances of side effects will be much less, because here you are optimizing vancomycin outcome according to the exposure. And that's the reason that the toxicities will be much less when you are using vancomycin TDM guided. Similarly, the meta-analysis looking at the beta-lactam antibiotics TDM guided therapy also shows the same thing. When you look at the target attainment, clinical cure, and the microbiological cure, all these factors are much higher when you are using beta-lactam's TDM guided therapy. So when you use antibiotics TDM, the clinical cure is improves. It is associated with the reduce the toxicities, reduced chances of treatment failure, and improved microbiological clearance. And for aminoglycoside and glycopeptide, the toxicities are much less when you use TDM guided therapy. So the patients who are on renal replacement therapy and the patient with septic shock, with severe illness, I think these are the patients who are going to get a major benefit when you are using TDM guided therapy. But for aminoglycoside and vancomycin, you have to use TDM guided therapy irrespective of critical illness. So we have to remember that. So even in our clinical practice, patient with a critical illness, you have made a correct diagnosis, you are giving a proper antibiotics in proper dosage. The chances of failure may be higher when you are not using TDM guided therapy. So you may fail despite you have done everything great to your patients, and the reason is that suboptimal drug exposure, which leads to the treatment failure. So correct diagnosis, correct treatment, correct dosage may not be sufficient. You have to incorporate your therapeutic drug monitoring in management of this patient, just like made to measure. So you are using the drug dosage according to the patient's exposure and according to the patient's drug level, right? So TDM gives the personalized antimicrobial dosage for a critically ill patient. Just take home message, the TDM guided therapy is well established for two groups of the drugs, vancomycin and the aminoglycosides. For selected patients, the beta-lactams TDM showed significant benefit. The TDM-guided therapy improves the microbiological cure and reduces the toxicities. And it also helps in improving the antimicrobial stewardship program because optimal exposures will reduces the risk of emergence of resistance. Thank you very much for the patience listening.
Any questions?